लाइव है सर, स्टार्ट। ठीक है, कुछ नहीं
ये
चाहिए।
ये मैं स्लाइड एक्सचेंजर देख रहा था, जरूरत नहीं है।
स्लाइड के लिए डायरेक्ट आप इससे कर दीजिए,
चलो
लाइव है। अभी लाइव हो जाए, इसको फुल स्क्रीन कर देते हैं।
हेलो हेलो कौन है? साउंड है? हेलो हेलो हेलो, am I audible?
स्टार्ट सर, फर्स्ट स्लाइड।
Okay, so
जस्ट ये एरो से फ्लिप करना है, एरो ये वाला।
good morning everyone. On the behalf of Academy of Critical Care Medicine Bhopal, Bhopal Surgical Society, Central Zone Association of Colorectal Surgeons of India, as well as the organizing committee of 28th Instructional Course and Faculty Exams, I would like to welcome all the delegates for this instructional course as well as prestigious fellowship program of Association of Colorectal Surgeons of India, that is FACRSI faculty. So the task which has been given to me by the faculty board is to cover the clinical features, etiology, as well as the medical management of Fissure In Ano. And what I have done is I have combined both the presentation in one presentation to complete my task. And this is the photograph which we are going to discuss in upcoming 20-25 minutes regarding this pathology. This is a case of basically Fissure In Ano. And in our clinical practice, whenever we are doing the procto OPD in my surgical practice, I am getting this type of patient. Every second or third patient is suffering from these problems. So there are various challenges in managing the cases of anal fissures. And what are these challenges? Number one is delayed consultation. Definitely, of course, these patients, they come to experts or proper proctologists after taking the consultations or by quacks, by taking the general practitioners. So definitely there is always delay in starting the treatment of anal fissures. Then when there is a delay, it will lead to the chronicity and as well as the recurrences. The anal fissures become the chronic phase, and then in that conditions we have to go for the surgical management. थोड़ा एक घंटे बाद बात कर लेना जरा, मैं केस में हूँ. Then the another issue is lack of fast pain relief, because the issue become chronic and then there is no role of analgesic. It just gives the symptomatic results. There will be a recurrence, poor healing rates, as we know that this area 12 o'clock position and 6 o'clock position is having poor blood supply, that will lead to the our healing process delayed. Inaccurate dosing and compliance, this is another issues, because sometimes when we prescribe the medicines, they take very irregularly, they apply these ointments very infrequently, and that will lead to the recurrences. And of course there are side effects of anal fissures like fistula formations, pain, bleeding, and all these things. Sometimes it may lead to the incontinence. So these are the basically 6 challenges which we are facing in management of anal fissure. So how we define the anal fissure? So as per the definition of anal fissure is, there is a tear starting from the mucocutaneous junction up to the dentate line. Sorry for the interruption. So anal fissure in ulcer like longitudinal tear in the midline of the anal canal. It is always distal to the dentate line. Discussing about the epidemiology, it affects all the age groups, both the sexes are involved, and mostly in female, when we compare with the male, anterior anal fissure is more common, particularly in childbearing age. And reason we know that because of the childbearing age, there is a fetus inside the pelvis which compresses the anal canal, which leads to the formation of fissure in ano, particularly in the anterior aspect of the anal canal. Now, how we classify the anal fissure? Classification can be done according to the duration, according to the etiology. Duration could be acute or chronic. When the fissure's duration is less than 6 weeks, and then it is called acute anal fissures. And usually, this type of fissure they respond very well with the conservative line of management. And when the duration of the fissures uh, reaches beyond the 6 weeks, then it becomes chronic one. It is called chronic anal fissures. And this is the condition when sometimes we have to think about the surgical aspect of managing this chronic anal fissures. According to the etiology, it can be divided into primary as well as in the secondary. Primary means there is no cause. The causes could be like heart stools, constipation, prolonged diarrhea, vaginal delivery, repetitive injury to the anal canal. These are the causes of primary development of fissure in ano. And secondary, especially inflammatory bowel disease. We have to rule out the inflammatory bowel disease like Crohn's disease, which leads to formation of fistulas as well as fissure in ano. We have to rule out the tuberculosis, HIV, syphilis, malignancy, rule out the history of sexual intercourse through anal regions, previous any previous anal surgeries. Another classification we can do according to the tone of the anal canal. If the fissure is present with the normal tone, this is called anal fissure in normal tone patients. When the tone is decreased, means hypotonia is there, then the treatment is different. And when the tone is increased, normal resting pressure is approximately 40 to 60 millimeter of mercury. And when it goes beyond the 80 millimeter of mercury, means hypertonicity is there. So that means patient is having acute anal fissure with hypertonicity, and then treatment will be different as compared to the when the tone is less. We can classify the fissure according to location of uh, fissure in ano in anal canal. Like it could be in midline and it could be laterally. Midline, we know the different causes which we have discussed, but laterally, if the patient is having anal fissures multiple and on the lateral aspect of the anal canal, then we have to rule out the various other causes like IBD, malignancies, anal trauma, all these things. So midline posterior anal fissure is about 70% cases usually we see, and midline anteriorly 25% in female and 8% in male, and both anterior and posterior anal fissure present in 3% of cases. Laterally, again, we have to rule out all these diseases like ulcerative colitis, Crohn's disease, HIV, sexually transmitted disease, malignancy, and leukemia. अभी 1 घंटे बाद बात कर लेना, थोड़ा सा बिजी हूँ. 1 घंटे बाद बात करना, भी बिजी हूँ. So what are the risk factors which leads to the formation of fissure in ano or anal fissure? Most important is the constipation. Whenever the patient is having constipation, passing hard motions leads to the trauma leads to anal spasm lead to the decreased supply to the particularly at 12 o'clock position or 6 o'clock position, which leads to the formation of fissure in ano. अभी बात मत करो, केस में हूं, है ना. Then low fiber diet. It is recommended that it is recommended that one should take about 25 to 35 grams fibers daily, and one should take all this gajar, chukandar, and all fiber containing diets in the our daily diets. Then obesity leads to the development of Fissure in Ano because it leads to formation of constipation, and constipation leads to the development of Fissure in Ano. Then women, particularly childbearing age, this type of patient, they may develop Fissure in Ano, particularly in the anterior aspect of an anal canal because of the pressure of fetus on anal canal. This is the pathology of anal fissures. Whenever patient is passing hard motion, it will lead to the pain, repetitive trauma. Ultimately, this trauma lead to the spasm of the internal anal sphincter, which leads to the increased tone of the resting anal pressure. It goes beyond 80 millimeter of mercury. Because of the increased tone, there will be less blood supply to the anodome, and whenever there is less blood supply, so it will lead to the local ischemia. बोला ना अभी 1 घंटे के बाद में बात करना, ठीक है ना? And whenever there is local ischemia, it will lead to the poor healing and ultimately leads to the formation of anal fissure, and this vicious cycle goes on, and this anal fissures ultimately turned up into chronic anal fissure. So these are the photographs which shows the characteristic of anal fissures. On the left side, you can see that this is a case of acute anal fissure. It is less than 6 weeks of duration. And the most characteristic finding of acute anal fissure is we can see the mucosal edges which are fresh. Sometimes they bleed on touch. And whenever these anal fissures become chronic, means more than 6 weeks, there will be a margin will be indurated. There will be a formation of sentinel pile. We can see the hypertrophic anal papilla, and as well as we can see at the base of anal fissure exposed internal sphincter fiber. This is the photograph of acute anal fissure. We can see there is a tear in the posterior wall of the anal canal below the dentate line, and we can see these mucosal edges are fresh. Another photograph, acute anal fissure. This is another photograph of acute anal fissure. We can see that formation of sentinel pile has been started. This is the photograph showing chronic anal fissure. We can see that sphincteric fibers are exposed at the base of anal fissure. So this is chronic anal fissure. This is another photograph of chronic anal fissure, exposed fiber of internal sphincter along with the sentinel pile. Here we can see that sentinel pile is there, base is exposed, internal sphincter fibers are exposed. Another, we can see there is a bleeding at the base and sentinel pile is there, characteristic of chronic anal fissure. So how we do the grading of anal fissure? Grade 1 means superficial linear tear. Grade 2 means deep linear tear associated with small sentinel pile. Whenever there is a small sentinel pile, it becomes grade 2. When this deep linear tear having margin which is fibrous, and when it is associated with sentinel pile, then it becomes grade 3. In grade 4, there will be always white tear with visible fiber of internal anal sphincter and associated sentinel pile. It means that in cases of grade 4, we can see at the base of the anal fissure exposed fibers of the internal anal sphincter. In grade 5, when hypertrophic anal papilla develops along with all previous signs, then it becomes grade 5. So this is grade 1, superficial linear tear. Grade 2, with sentinel pile. You can see sentinel pile at 7 o'clock position. This is grade 3 deep linear tear with fibrous margin associated with sentinel pile. Grade 4 wide tear with visible fiber of internal anal sphincter as well as association of sentinel pile. And in grade 5 we can see that there is hypertrophic anal papilla along with the previous sign. So how to do the clinical examination of anal fissure? History, physical examination, inspection, palpation, digital rectal examination, as well as anoscopy if patient pervis. History is always very typical. In this patient, history is always very typical. These patients, they complain of severe pain while passing the motion. It starts while passing the motion. It persists up to the 4 to 5 hours after passing the first motion. Then it gets subside. Usually the patient applies some ointment, local anesthetic, something like that. This pain is always the characteristic of this pain is just like stabbing has been done, or sharp and cruciating type of pain. And the blood is not massive one, but it's a streak on the stools. The characteristic feature of the bleeding anal fissure is streaks of blood on the stools. Little bit amount of blood is there. So this is the classical history. With this complaint, patient usually they come to our OPD for the treatment. Now the physical examination can be done in left lateral position for right-handed person, can be done on right lateral position for left-handed person. It can be done in lithotomy position, ideal position in which we are doing the surgeries. But usually we perform the physical examination in left lateral position in our OPD. Inspection, we have to see so many things because anal fissure can be diagnosed just simple examination of the perineal region. We have to rule out other pathology like malignancy. We have to rule out the other condition like fissure in ano, whether there is any external opening, any mucosal discharge, condition of the skin. So all these things should be kept in mind while examining the cases of anal fissure. Then come to the palpation. We have to see whether this patient is having any complication because of the anal fissures. Patient might develop intersphincteric fistula or subcutaneous fistula. There might be having pus discharge from the wound side. This patient may have chronic condition of the skin, means dermatitis may be present because of the irritations and pus discharge. So palpation should be done of the sentinel pile to rule out the infection. Usually these patients, they don't allow you to do the digital rectal examination or anoscopy. It itself suggests that the patient is having acute anal fissures. But digital rectal examination and proctoscopy is very important. We ask the patient to apply lubricant jelly or lidocaine jelly for 5 to 10 minutes, wait half an hour. If possible, we should do the digital rectal examination to rule out the other pathology. Even if it is not possible, then we can do the digital rectal examination or anoscopy under anesthesia. But if patient is not allowing you to do the digital rectal examination, means patient is having severe acute anal spasm and one should think about the anal fissure. Now, is there any role of anal manometry in the diagnosis of anal fissure? Yes, of course, there is a role of anal manometry in diagnosis of acute anal fissures. Normally, we know that the resting anal fissure is 40 to 60 millimeter of mercury. If it is more than 80 millimeter of mercury, it means there is increased anal tone. And when the pressure is decreased less than 40 millimeter of mercury, means patient is having fissure in ano, probably with hypotonicity. That time we have to think of mucosal advancement and other procedures. So nowadays scientists have developed, although anomanometer is available and we can assess the pressure inside the anal canal, but they have developed this uh, sensors which we can wear our index finger, and then we can see all the digital data on the skin. Soon it will be available in Indian market also. So what are the complications of anal fissures? Infection, bleeding, and fistula formation. Fistula formation could be subcutaneous forms. When it is beneath the subcutaneous plane, there will be pus discharge, intersphincteric space. Usually, these two type of fistula formation is very common with acute anal fissure when it is not treated. So this was regarding the first part of my presentation. Now coming to the non-operative conservative treatment, how to medically manage these type of patients. So what are the different goals? So the first goal is treatment of underlying pathology. We have to rule out the underlying pathology, which is giving rising to the formation of acute anal fissures. So we have to treat that pathology. Second thing is we have to relax the internal anal sphincter because of the increased tone. And third is elevation of the symptoms. We have to treat the symptomatology of the patient. Coming to the dietary modification, the entire presentation of this medical management, I have divided into dietary modification, sitz bath, medical management, pain management, laxative, tropical agents, GTN, glycine, calcium channel blocker, nifedipine, diltiazem, botulinum toxins, and surgical management. So what are the recommendations? Association of Colorectal Surgeons of India have 7 parameters, guidelines. They have published the guidelines to treat the Fissure In Ano. And for the diet and sitz baths, non-operative measures like sitz bath, high fiber diet, with or without topical anesthetic agent should be recommended as the first line treatment for acute anal fissure. A strong recommendation based on moderate quality evidence 1B. Sitz bath. This is very important. There is controversy whether this sitz bath is effective or not, or if it is effective, how much duration patient should take the sitz bath. So the effect of sitz bath is that it gives very soothing effect to the patient. It relieves the pain. It decreases the anal tone. While giving the sitz bath, it improves the hygiene of the particularly perineal regions. So ultimately, sitz bath, in my practice, I have also seen that sitz bath is very effective in elevating the symptoms of acute anal fissures. Now, second question is, how much duration? 15 to 20 minutes daily, morning, evening, and if patient desires, he can take the sitz bath in the afternoon also. And one study has been done. What should be the temperature of degree centigrade? There is no decrease in anal tone. But once patient takes the sitz bath with 40 degrees centigrade of water, it decreases the symptoms, it decreases the anal tone of the patients, and patients usually comfortable after taking the sitz bath. Pain management. So definitely these patients, they are having agonizing pain, and we have to do proper pain management. The treatment of choice is always start with the simple paracetamol, which can be prescribed as per the weight, 500 milligram to 650 milligram QID or TDS. If patient is not responding, then we can go for tramadol and diclofenac as per the experience and choice by the surgeons. Now coming to the laxative, osmotic agents as well as bulk forming agents. So lactulose, milk of magnesia, PAG, sorbitol, they are very effective osmotic agents which relieves the constipation. Regarding the bulk forming, these methyl cellulose and psyllium, they are very good bulk forming agents for relieving the constipation. But according to the American Society of Colorectal Surgeons, they recommended that sometimes it has got a it has got a uh, uh, I can say that other effect, means patient can pass stool, but because it is a bulb forming laxative, it can produce the trauma to the anal canal, and it can worsen the symptoms of patient is if the patient is having anal fissure. So one should be very watchful, and one should take care of while prescribing the bulb forming stool in cases of anal fissure. It can sometimes it can worsen the symptoms of anal fissure because it is forming the bulk stool, and which can lead to the trauma to the anal canal. Coming to the GTN, is there any role of nitroglycerin? Yes, of course, it has got a very good results. And during our post-graduation days, we used to treat the fissure in ano cases with the GTN. It releases the nitric oxide, which is a vasodilator, and it relaxes the uh, fibers of the internal sphincter. Basically, it is a muscle relaxant. But the side effect is that it produces severe headache. So earlier we used to prescribe this GTN nitroglycerin ointment, but because of this severe headache and all this problem, Government of India has withdrawn this molecule from the uh, Indian market, and now it is not available. So we cannot use this molecule for treatment of Fissure in Ano. So it is obsolete now. So what is the ACRSI recommendation for use of nitroglycerin in cases of fissure in ano? Tropical nitrates can be used to treat anal fissure, but it is not available in India now. Severe headache leading to poor compliance, strong recommendation based on high quality evidence 1A. Coming to the calcium channel blocker, nifedipine calcium channel blocker, which blocks the calcium channel, it lead to the relaxation of the fiber of the internal sphincter muscle, which are the smooth muscle fibers. Nifedipine and lidocaine, nifedipine available itself in a ointment form or jelly form, and when it combines with the lidocaine, because local anesthetic is involved with this cream and ointment, it gives soothing and very relaxing feeling to the patient, and it alleviates the pain also. It is available from 0.3% is nifedipine, and lidocaine is available in 1.5%. Nowadays, many companies they are coming with the 3% lidocaine to increase the dose of. They are increasing the dose of lidocaine. Then it is going to be more effective. Then diltigem again available in different forms. Calcium channel blockers, same mechanism of action. It is available in 2% form, with or without lidocaine. Now the ACRSI recommendation on calcium channel blocker. Calcium channel blocker, diltigem and nifedipine may be used as the first line treatment of acute and chronic anal fissure. They have fewer adverse effects and are well tolerated with increased healing rate and low recurrences rate. A strong recommendation based on high quality evidence 1A. Now coming to the botulinum toxin, it is derived from the Clostridium botulism, and it has a strong recommendation based on low and very low quality evidence 1B. Botulinum toxin can be considered as a safe and effective treatment for anal fissures resistant to medical treatment and before offering surgical options. Means that it is a bridging treatment therapy between medical management and surgical management. Now, how much dose we have to give? We have to give. So this Botox is available in form of oil, dried powder, 15 international unit. One has to use this syringe, insulin syringe, or this tuberculin syringe, and one has to dissolve this 50 international powder with 2.5 ml of distilled water, make it 2.5 ml, means 1 ml become 20 units, another 1 ml becomes 20 units, and 5 ml is 10 units. So 5 ml is extra. one has to give 20 international unit in right side away from the anal fissure. We have to give in the healthy part of the belly of the internal sphincter fibers. The procedure can be done under local anesthesia or pudendal nerve block, or if patient desires, one should go under the saddle block or general anesthesia. And one should take the precaution while injecting this Botox in the fiber of the internal sphincter fiber, that it should not goes in external sphincter. Otherwise, patient may develop incontinence. Although the effect is reversible, but it takes, sometimes it takes 4 to 5 months for reversal, because effect persists for 4 to 5 months of these Botox injections. So this is Botox spasmolysis, BOS therapy. So managing fissure in special conditions like children, always start with the conservative management. If patient is not uh, responding, children are not responding with conservative management, then go for calcium channel blocker, especially diltiazem. And if it becomes chronic and if requires surgery, definitely we have to go for lateral internal sphincterotomy along with the fissurectomy. This is the strong recommendation based on low and very low quality evidence 1C. In cases of pregnancy, how to manage it? Always try to manage the patients in conservative line of management, with sitz bath, fiber containing diets, avoiding the constipation, and one has to try to pass the pregnancy period. And even after pregnancy patient, if patient is not responding with the conservative line of management, we can go for surgical. And if at all needed to go for surgery in pregnancy time or ANC period, then second trimester is always the best trimester to go for the surgery. In cases of Crohn's disease, IBD is always present in form of fissures, especially Crohn's disease. They always present in form of multiple fissures, multiple fistulas, and we have to treat Crohn's disease by conservative management of treatment. If patient develop fistula, definitely we have to go for sit-downs and other managements. In cases of HIV, we have to go for CD count, calculate it, take the opinion of physician, and then manage the patient on conservative line of management. No role of surgery at all. Managing fissure in special condition like anal tuberculosis, we have to, because the primary pathology is tuberculosis, we have to manage this patient on conservative line of management. Try to manage the tuberculosis part for at least 6 months. And if patient is not responding, in cases of a tubercular patient, after taking the tuberculosis, entire treatment of tuberculosis, then one can go for the surgical part, the surgical management of fissure in ano in anal tuberculosis patients. This is algorithm of management of fissure in ano. So key concept, acute anal fissure symptoms less than 6 weeks are typically treated first with non-operative conservative management with high healing rates. Calcium channel blockers have similar efficacy rates with topical nitrates and fewer side effects. They are considered first line of treatment for chronic fissures. Botulism toxins injection is considered second line of treatment for managing the chronic anal fissures. So welcome all of you for this 28th instructional course from 2nd to 6th April here in at AIMS. इसके बाद there will be another e-brochure of Academy of Critical Care Medicine Bhopal, which will inform them regarding the today's delegate dinner, 8 p.m. onwards, along with the quiz by Dr. Santosh Bhaskar.